Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Novartis, Allergan, Janssen, Biogen, AGTC, MeiraGTx, and the SickKids Foundation. We'd also like to thank Accessible Media Inc., our national accessibility partner. Everyone should download the AMI app, which is a fabulous resource, and you can watch excellent programming, including previous Fighting Blindness Canada events. Thank you for watching. We hope you enjoyed this webinar and share your thoughts with us in the comment section below. So it gives me great pleasure to introduce you today to Dr. Yvonne Buys, who's a glaucoma specialist and professor at the University of Toronto, Department of Ophthalmology and Visual Sciences. She's a past president of the Canadian Ophthalmological Society and of the Canadian Glaucoma Society. So I'm going to turn it over to you, and we're going to learn all about glaucoma today.
Okay, let me just get to starting the slides here. So first of all, I wanted to thank Morgan and also Fighting Blindness Canada for inviting me here today to talk to you a bit about what is glaucoma. And I think it's really a timely time to be talking about eye diseases and glaucoma because, as you're probably aware, World Sight Day is on Thursday this week. So what is glaucoma? A lot of people think of glaucoma as just one disease, but glaucoma is actually a whole group of diseases that can result in gradual vision loss. So vision loss with glaucoma usually starts by losing your side or peripheral vision, but if left untreated, glaucoma can cause complete loss of vision. So to better understand what happens in glaucoma, we first should maybe review how the eye works. So here I have a cross-section of the human eye, and you can see at the front on the left-hand side, that's the cornea. Then you have the colored area, your iris. There's a lens. Inside the body of the eye, we have something called vitreous humor. And the back wall of the eye is lined by the retina, and one special area in the retina called the macula, and then you have the optic nerve, which transmits the information from the retina to the brain. So again, how the eye works, light comes in through the pupil, it's focused mostly by the lens to the back of the eye, and mostly in a specified area around the macula, and then that image is transmitted to the brain and produces what we look at as vision. The optic nerve is the really important part in glaucoma because that's where you see the damage happening. The optic nerve is made up of individual nerve fibers. There's about 1.2 million axons, and they have to carry that visual information to specific points in the brain in order for what you're seeing to be perceived as an image. In glaucoma, what happens is the fluid inside the eye doesn't drain properly. So normally the fluid is produced by a structure just behind the iris, and it circulates to the front of the eye around the pupil and drains in an area we call the angle or the trabecular meshwork. So in glaucoma, there's a problem with the drainage, and the fluid builds up, it has nowhere to go, and the eye pressure increases, and that increased eye pressure pushes on the back of the eye, specifically at the optic nerve, causing damage to the axons. So when the drainage is blocked, this increases the pressure, and it's called high intraocular pressure. Most people will say high IOP, intraocular pressure. High eye pressure sometimes is also just called ocular hypertension. And we don't call high eye pressure necessarily glaucoma because some people can have high eye pressure and not get glaucoma. So we don't define glaucoma by a level of eye pressure, but as you'll learn later on, glaucoma is treated by lowering eye pressure. One of the problems, though, in glaucoma is that typically you cannot know or you can't feel when your eye pressure is high. So over time, this pushing on the back of the eye from the high eye pressure damages the optic nerve and can affect your eyesight. And as I said, if it's left untreated, it can result in complete blindness. There are many types of glaucoma, but I'd like to broadly break these down into open-angle glaucomas, of which there are many, but well, let's just think about open-angle glaucomas, closed-angle glaucomas, and congenital glaucomas. So that's when children are born with glaucoma. I'm not going to really talk about congenital glaucoma today. I'm going to focus more on the open and closed angle. Open angle glaucomas are mostly high pressure glaucomas, but there is a subset that we call low or normal pressure glaucoma. So these are people that get all the signs of glaucoma, the damage to the optic nerve, lose the peripheral vision, but don't really have high eye pressure as you would expect when we look at what are population normals for eye pressure. In closed angle glaucoma, we think of two types: chronic, so slowly developing, and acute or sudden. Open angle glaucoma is the most common type of glaucoma. And again, I'm not going to get into a lot of detail, but there are primary open angle glaucomas, but it can be secondary to other things. It's caused when the exit for the fluid inside the eye doesn't work well and makes the eye pressure goes up. It is usually not associated with any symptoms of pain or redness, and early on it can damage the optic nerve without you noticing. So in fact, if a patient comes to me noticing they have a problem with their vision and they have glaucoma, unfortunately, they already probably have advanced disease. Low or normal pressure glaucoma is a type of open angle glaucoma that has all the features of glaucoma, but doesn't have high pressure. But still, it's treated the same way because the only risk factor that we're able to treat in glaucoma is eye pressure. So at first, when people are having glaucoma, they usually will not have any visual symptoms at all. And that's because there's a lot of redundancy in the visual system. You have to lose a lot of axons before you'll actually notice it. Even as the disease increases and is damaging the optic nerve, usually your central vision still stays good. You start, though, to lose peripheral vision. So this is kind of the opposite from macular degeneration, which some of you may have heard of, where you lose your central vision first, but maintain your peripheral. So in glaucoma, you lose your peripheral vision first, and if it goes untreated, you can lose all your vision. In closed angle glaucoma, as the name suggests, there's actually a physical barrier for the fluid getting through that exit site. So it's like an anatomical problem. There are two types: chronic, when the eye pressure rises gradually, and acute or sudden. That's when the eye pressure goes up very rapidly within hours and can quickly damage the optic nerve. Acute closed angle glaucoma has a very dramatic presentation. When people present to this, where people are developing it, they will usually go to the emergency department because they know something's wrong. They can have severe eye pain to the point of vomiting, have sudden blurred vision or loss of vision. Their eye is often red. They can be seeing halos around lights and have headaches. This is a medical emergency and has to be treated urgently to be sure to maintain vision. So in all the types of glaucoma, open angle, angle closure, prolonged elevated eye pressure will lead to a slow and gradual loss of peripheral side vision. The loss of vision will seem like you're looking through a tunnel, and over time, even that straight ahead vision can decrease until no vision remains. So that's why it's important to be aware of the disease glaucoma. Why are we talking about glaucoma? Glaucoma is a common disease. It affects nearly 70 million people worldwide. Glaucoma is responsible for approximately 12% of global blindness. Glaucoma is the second leading cause of vision loss of Canadians over age 65. Over the next 25 years, it's estimated that nearly 500,000 Canadians will be living with glaucoma. So I'd like you now just to take a second and ask yourself, did you know what glaucoma was before today? Did you know that glaucoma could lead to blindness? This lack of awareness of glaucoma is a big problem because, as I said early on, there are no symptoms. About 50% of the people with glaucoma in the developed world are unaware they have glaucoma. And if you're unaware you're having glaucoma, then you are not on treatment, which is a real problem since glaucoma vision loss can be prevented in most people, but you need to diagnose the disease early. So how do we diagnose glaucoma? Because glaucoma has no symptoms, you have to be having routine eye exams to know if you have glaucoma or not. And this is really crucial to detect glaucoma early. What happens in an eye exam? Well, one of the main features I've been talking about is eye pressure. So one part of any glaucoma assessment, or really any comprehensive eye examination, should include measuring eye pressure. And that's something we call tonometry. So we want to measure the eye pressure to make sure it's staying at a safe level. And you can see here these images are of a patient who's sitting up at an instrument we call a slit lamp, and there is a small sphere being brought forward. It actually touches the surface of the eye. And through the way it touches the eye, we're able to measure the pressure inside the eye. When you're having your pressure measured, I think it would be useful, especially if you have your glaucoma, to ask your doctor, what is your pressure? And to record it for both your right and left eye. And you may even want to write down what day and what time of day it is, because pressures change during the day. And it would be useful also to ask your eye care professional, what is their target pressure for you? So you know what is a safe number. Another big part of a glaucoma examination is looking at the optic nerve, because I said that's where you see the damage. On the right, you can see an image of a normal optic nerve. So the nerve has these red lines, which are your arteries and veins. And this circular area here that I'm trying to show you is the nerve. So in a healthy nerve, we see this pink area on the outer part. This is called the neural retinal rim. It's those axons that are entering from the eye to the brain. And in the center, we have an empty space. And when I look at the eye, at the optic nerve, I can see it in 3 dimensions. So that empty space sinks back like a cup, and we call that a cup. So this is what we say, normal looking cup. It's about 1/3 of the area. In glaucoma, as you can see on your left, the neuroretinal rim is much thinner because so many of those axons have died, and the cup is much larger. So this is what an optic nerve with advanced glaucoma would look like. So we look at the optic nerves directly, but we can also do tests to measure the optic nerve. And one test is called the OCT, Ocular Coherence Tomogram. And in this, it takes a topographical image, like a map of the back of the eye, focusing on the optic nerve. And it's useful for two reasons. One, you can measure a person at one time and get some idea, you know, what do their nerve fibers look like? Does this look like a nerve from glaucoma? But I find it even more useful when you follow a patient over time, because the machine will keep checking the patient against their original images, so you can see if the nerve is changing over time, which is really important. Another very important test in glaucoma is the visual field test. So during a visual field test, again, similar to a slit lamp, you do this one eye at a time. So one eye will be covered, and you'll see a light, and you focus at that dot. And whenever you see a flashing light, you press a button. And this way, a visual field test can measure those areas where you're not seeing. So you can see here at the bottom a progression of visual field tests. So you start with the normal one. Black is where you're not seeing. So this black area is actually normal because that's where the nerve enters the eye. So there's no tissue there to see images. But as this black area increases, this is not normal, and this is moderate and then advanced glaucoma. Other common tests that are done in an eye examination are measuring your visual acuity. So you're asked to identify letters of the alphabet. There are other ways they can do it with pictures as well, or what we call an illiterate E. So we tumble an E around and the patients will point in what direction the lines are. Another important thing for glaucoma is something called gonioscopy, because as I mentioned early on, the main division of glaucoma is an open or closed angle. Well, we can't see the angle directly when we look at a slit lamp. We need to put a lens on the eye to be able to use mirrors to look into the angle. So gonioscopy should always be done the first time a patient is seen, and sometimes repeated over time, because it can change as you get older, and it helps to see if you're at risk of angle closure. Many vision and ocular health conditions are not always accompanied by recognizable symptoms. Often there's an increased risk to the patient if timely treatment is not initiated. And this is why regular complete eye exams are important, because they help the early detection of conditions like glaucoma that could affect your eyesight and are treatable. So you want to catch these diseases early. The Canadian Ophthalmological Society recommends regular eye exams for people of all ages. And in this table, we have what the recommended frequency is. And I just wanted to highlight for those over age 65, it's recommended that you have a comprehensive eye examination at least every 2 years. Of course, if you're having any concerns, you should go more often. The good news is, if glaucoma is detected early, there is a high chance that you will not go blind from glaucoma. So again, stressing how important it is to be diagnosed early. Well, how do we treat glaucoma? The overall goal is to reduce eye pressure. As I said, this is the only modifiable risk factor for glaucoma, lowering eye pressure, even in those who we say have low or normal pressure glaucoma. By lowering eye pressure, we know it slows down the damage to the optic nerve, which can preserve your sight and preserve your quality of life. The main form of treatment for most patients is with eye drops or occasionally pills. Eye drops work by decreasing how much fluid is made, and some eye drops work by increasing the outflow of fluid, and some drops do both. We currently have 7 classes of glaucoma eye drops, and they all work on different mechanisms as shown in this complicated diagram on the right. Each class often has more than one drop that's available. So lots of drops available for glaucoma. These either come as the single active ingredient, and we also have combination drops that have 2 or more ingredients in it. So it makes it a little bit easier for patients. They don't have to use so many bottles as often. But eye drops are a real challenge, and the challenge is non-compliance. Up to 80% of glaucoma patients are non-compliant with their topical medications. And this is a problem because non-compliance will lead to uncontrolled eye pressure, progression of glaucoma, and increased costs because you may be having unnecessary switching of drops or unnecessary surgery if your doctor thinks the drops aren't working, but maybe they aren't working because they weren't put in the eye. Aside from medications, we have other ways to treat glaucoma, and one of these is laser. So in open angle glaucoma, there's a type of laser, most people now do what's called SLT, selective laser trabeculoplasty, where laser energy is directed to the structure that drains fluid to make it work better. There's also a laser for angle closure glaucoma, and this is the only type of glaucoma that we can cure. Primary angle closure glaucoma. And what we do is make a small hole in the iris, which is shown here with the arrow, and it helps to bring back the iris and remove that physical blockage to the drainage structure. And we also have surgery for glaucoma. So surgery is done to mostly make a new drainage outlet. Some of the newer procedures are trying to target the existing drainage and make it work a little bit better. People can have multiple surgeries on the same eye. They can have different types of procedures. The most common still is a trabeculectomy, as shown in this schematic on your right. We also insert glaucoma drainage devices. So this is an image of the traditional glaucoma drainage device. So it's a big plate that's put on the side of the eye with a tube that goes right into the eye. And more recently, we have a whole bunch of these new procedures called MIGS, minimally invasive glaucoma surgery, that are trying to make use of the traditional pathways and see if they can make them work better. And some are also trying to use the same pathways that are used in a trabeculectomy. So how do you know if you're at risk for getting glaucoma? Anyone can get glaucoma. So even if you don't have these risk factors, you could get glaucoma. But there are things that make your risk higher. So older age. As the age increases, the proportion of people with glaucoma goes up. Female gender. If you have a family history of glaucoma, so that's why it's really important that glaucoma patients let their siblings know that they have their glaucoma and let their children know so they can make sure they get themselves evaluated. People of African or Hispanic descent have a higher risk of open angle glaucoma and usually have a more aggressive form of glaucoma. Those of Asian or Inuit descent have a higher incidence of angle closure glaucoma. Diabetes or high blood pressure are also known to be risk factors for developing glaucoma. After an injury to your eye or a surgery to your eye, sometimes you can get secondary glaucoma. People with nearsightedness are at higher risk of open angle glaucoma. And high eye pressure. As I said early on, this doesn't define glaucoma, but if you have elevated eye pressure, you are at higher risk of getting glaucoma. And sometimes we will treat you even though you don't have glaucoma yet, just because the risk is high. The most important thing that you can do is have a regular, complete eye exam to have yourself screened for glaucoma. The other things, if you have glaucoma, is take your medication as directed. Manage those other risk factors like diabetes and high blood pressure. Try to protect your eyes from injuries and infections. And talk to your doctor before starting any new medications, even over-the-counter medications, because some can be contraindicated in glaucoma. The main one for open-angle glaucoma are steroids, and for angle closure, if you haven't had an iridotomy, you want to avoid a lot of over-the-counter medications like cough suppressants, sleeping pills, pain medication, because they can sometimes provoke an attack. So if I have glaucoma, how do I live with glaucoma? It can impact your life. Vision loss can cause problems to do your daily routine activities because it narrows your field of vision. You can have blurred vision, reduced ability to see fine details, a difficult time adapting to changes in light. So coming from the sunshine outside to a dark room can be a challenge, and trouble seeing in dark places. So the key takeaway messages today are: glaucoma usually has no early symptoms until irreversible vision loss occurs. Regular routine eye exams can help identify glaucoma early. If you have high eye pressure or glaucoma, follow the treatment plan that your doctor has provided. But if you're finding problems like with side effects, costs of medications, or inconvenience, please let your doctor know, because as I showed you, there are other treatment options aside from medications. We have to find what's best suited for each patient. The best chance of preserved vision over a lifetime is to diagnose glaucoma early. So that is the end of my presentation, and in a few minutes we'll take some questions. But I just again wanted to highlight for World Vision, World Sight Day, a website that the Canadian Ophthalmological Society has just updated called See the Possibilities. And if you go to that website, www.see, that's S-E-E, thepossibilities.ca, you can get a lot of information about the major eye diseases. They also have a way that you can check for risk factors for these diseases. You can check your vision and also do a test for macular degeneration. And there's a number of other useful information there for patients. Okay, thank you very much.
That's great. Thank you so much, Dr. Buys. So we're looking forward to everyone's questions now. So there's a couple ways that you can ask your questions. So at the bottom of the Zoom, there is a button called Q&A, which you can click, and at any time you can type a question into that box, and I will get those. You can also email me at education@fightingblindness.ca, and I am monitoring that account as well. So just while I give you all a moment to get your questions in, I just want to take a short pause to thank our supporters and monthly donors who are tuning in today. You know, we can't do what we do without your support. And you know, research is expensive and it's a long-term investment, but the results can be life-changing. So for anyone who's interested in joining our community of core supporters, you can make a tremendous difference today by joining our monthly giving program. For as little as $1 a day or even $10 a month, your gift can make a big impact for people living with vision loss. And there's a couple of reasons that we always talk about our monthly giving program. One is that it really provides us with a reliable and consistent source of funding that ensures that we can make long-term investments in research, but it also reduces our administrative costs so that more of your money can go directly to the important vision research that we're funding. So if you're interested in joining, you can visit us at fightingblindness.ca, or you can always call us at toll-free at 1-800-461-3331. All right, so let's get into the questions. I have a bunch from email, and I see some people have been busy typing away. So let's start right here. We have a question from Maria, who says, "Are eye drops for the macula also effective for glaucoma?"
So I think, Maria, you're asking about the disease macular degeneration. So that's a very different disease from glaucoma. And I'm not even aware of an eye drop for macular degeneration right now. It's mostly injections in the eye and sometimes laser, but any treatment for macular degeneration would not be a treatment for glaucoma. In fact, The injections for macular degeneration, unfortunately, often cause patients' eye pressure to go very high afterwards. And there is some concern that that might be causing glaucoma. And actually in British Columbia right now, the government is doing a big investigation on this. So if you are getting injections in your eye for macular degeneration, I would urge you to ask your ophthalmologist, check your eye pressure about 30 minutes after to make sure that it's not dangerously high.
That's very good information. I didn't know that. I have a question from Fran. I'm going to try to pronounce this correctly. But Fran says, can you please comment on pseudo-exfoliation glaucoma and cataract surgery? Are there particular precautions that should be taken in order to have a positive outcome?
Okay, so that's a really good question. So as I mentioned, there's lots of different types of glaucoma. And open angle glaucoma, primary open angle glaucoma, is the most common. Of secondary open angles, pseudoexfoliation would be the most recognizable type of open angle glaucoma. So in pseudoexfoliation, there's a dandruffy material that's released. They actually don't know where it comes from, but you can see it accumulating on the lens of the eye, and it actually blocks the trabecular meshwork. Now, I said, glaucoma happens more as we get older. Well, what else does? Cataracts. So very common to have a patient that has both glaucoma and cataracts at the same time. Pseudoexfoliation may also cause cataracts to come a little bit quicker. There are concerns of cataract surgery in people with pseudoexfoliation because the ligaments that hold the lens in place become fragile. And sometimes during surgery, even when you don't have pseudoexfoliation, there is a risk that pieces of the lens may fall into the back of the eye, and then you usually would require surgery from a retina surgeon to remove those fragments that have fallen backwards. So for people who have pseudoexfoliation, I think it's probably not a bad idea to have your cataract surgery a little bit sooner rather than later, because as the lens gets thicker and harder, it does make the surgery a little bit more difficult, and it may increase your risk of this complication. And you just want to be sure that you're with an ophthalmologist that feels comfortable in operating in someone with pseudoexfoliation. And they should kind of assess the lens in your eye, because there are ways to see if the lens is already quite unstable, and then there's extra things that they can do to try to minimize the risk of particles falling to the back.
That's great. And actually someone, I think Maria in the chat just asked, what is pseudoexfoliation? Could you clarify that for people who may not know what that means?
Okay, so it's a dandruffy material that accumulates in the eye, not just in the eye, they find it in other parts of the body, like in the heart. They found it in joints as well, but they don't know what it does there. But they don't know what the material is. It's thought that maybe it's an elastin type of material, but it's not really clear exactly what it is. But it's this material that you can see it on the lens of the eye. It creates like a little circle, and it looks like dandruff, and those flakes come off, and you can just imagine them clogging the area where fluid drains out of the eye, and that's where they cause glaucoma.
Clarifying that. So this is another question that I hear a lot, or a topic that's very popular, about cannabis. So Lori's asking, what about cannabis being shown to lower intraocular eye pressure?
Well, Lori, you're asking the right person, because I've written the Canadian statement on cannabis and glaucoma. So we do know that smoking marijuana will lower eye pressure. The other ways of ingesting it or using a drop on the eye are not effective to lower eye pressure. So the only method that works is smoking. And unfortunately, the side effects of smoking marijuana, the effects on your mind, you cannot separate them from eye pressure lowering. The eye pressure lowering is only active while you're having those other psychotropic effects. So the Canadian Ophthalmological Society does not recommend using marijuana as a treatment for glaucoma, because basically you'd need to be stoned all the time. And in addition, the risks of smoking for your rest of your health have to be considered too. We have so many good treatments for glaucoma with drops, laser, and surgery. I think that marijuana just has too many risks.
Interesting. And, you know, this is kind of my own question, but in your talk, you were talking about how glaucoma drops have such a low compliance rate. Is there any like research done into why that is? Like, why are people not being compliant with their medication use?
Okay, I was going to put a slide and I decided not to, but I've published a number of papers on that. It's multifactorial. I think a lot of it is just the inconvenience of using them. They do have side effects. Like I said, glaucoma is a silent disease. So if you don't see the benefit of using them, you kind of wonder, you know, sometimes why should I use them? We just also recently finished a study looking at the costs of glaucoma medication. So specifically for those under age 65 who don't have ODV coverage, that can be a barrier too for using medications. So it's just inconvenient, the frequency, the side effects, that unfortunately we have a very high non-compliance rate.
I think that's, you know, goes back to what you're saying, awareness is so important, right? Like you said, if you're not seeing, you know, an effect daily from taking the drops, you may not be as interested in taking them, right?
Yeah, and I think it's education as well. And that's why I would urge people with glaucoma to ask your ophthalmologist, what is your target pressure? And each time you're in, write down what your pressures are. I think it starts to give you an understanding of the purpose of the treatment.
Yes. Okay, I have another question here from email. I think you touched on this a little bit in your talk, but Adele has a question about steroids, if someone is a risk for developing glaucoma. So more specifically, she's asking, are there any guidelines available for people who are at risk of developing glaucoma, who also may have asthma or seasonal allergies, like on how to use steroids? You know, she's had different things. She's used low-dose steroids, nasal sprays, inhalers. Just wondering what she should be doing there.
So steroids are a big risk for causing glaucoma. But what I didn't say is how you administer them. So they're really a risk if you put it as the steroid drop in the eye or a cream around the eye. Using steroids like as a nasal spray or for asthma, I don't believe there is a risk. We did a study where we took patients who we knew were high risk to respond to steroids, so people with high eye pressure, ocular hypertension, and we gave them a nasal spray with steroids, and half the group got a placebo. And we didn't have anyone who had a response to their eye pressure by using the inhalation or the nasal spray of the steroid. So I think that I would not be worried about that. I also don't believe that people who take it orally, I never really see that in practice for that being a problem, or had injections into their joints of steroids. So steroids, the concern is when you use it as a cream around your eyes or a drop in your eye.
Okay. Let's see here. I have a question in the Q&A from Sherry. So Sherry's saying, I need a strong magnifying glasses to read anything, even a half-inch print. Is this caused from glaucoma or AMD? She also has a problem seeing in the dim light and is wondering what causes that.
So in glaucoma, like I said, it's usually loss of peripheral vision. So I think that's one of the problems, you know, with the friends and family understanding visual disability for people with glaucoma. They could look at very fine print and be able to see it, but they don't see when you come from the side. So I think what you're describing and having to use a magnifier, etc., very unlikely to be glaucoma. The number one reason that people have problems and need magnifiers actually is presbyopia, or as we get older, that we need glasses correction. I'm assuming you've had a look at that. So if it's beyond that, it may very well be macular degeneration. And you certainly should be seeing somebody because there is treatment for macular degeneration.
Okay, another question here from email. Stephen asked, he said he's interested in how traditional trab surgeries interact with new and developing MIGS. Is it possible to get a MIGS treatment, so in focus, microshunt, or Zen stent, after having a traditional trab?
Yeah, it is possible to have them after a trab. So a trabeculectomy, you're making an opening from the inside of the eye to drain the inside fluid in the eye to the subconjunctival space. But you're only using a very small amount of geography of the eye. So we're going like around the whole circle. You got a lot of space there. So if you've had only one trabeculectomy, even if you had two, you likely would have room for those other types of procedures. My only caution with some of the MIGs is that their effectiveness is a little bit limited. It's usually not for advanced glaucomas. Some of the newer ones like the Zen may get you a low enough pressure. A Zen is very much like having a trabeculectomy because they're just using a tube to make that conduit rather than doing all the other incisions in a trabeculectomy. So my concern with some of them, like an eye stent, is that they probably don't lower pressure enough. And you always have to be cautious with new technology, because new technology is that, it's unproven, right? So maybe it'll be great, but we still don't know. We don't really have long-term results on a lot of these MIGs at this time.
So building off that, Christina also asks, are there side effects from the filter surgery for glaucoma? Is it better to have filter surgery rather than MIGs once vision loss has begun?
So there are side effects. So side effects from MIGs too, right? Any time you have a procedure done, there is a risk that you can lose vision. The risk is low, but it's not zero. In addition, in a trabeculectomy, there are other side effects with surgery. Often your eye won't really feel the same anymore. You could have problems with irritation and a dry eye. Sometimes you can see it a little bit, the bleb that we make with a trabeculectomy, so it might change your appearance a bit. So I never think that people should really go lightly into surgery. If you are noticing your glaucoma, it sounds then probably that it is advanced. So you would want to have a procedure that's really going to lower your pressure well. And that's the one thing that you would want to be sure about when a MIGS is suggested, that they're picking one that maybe has a better chance of getting a low pressure. And again, unfortunately, you don't know how long that's going to be. So remember, none of these procedures are a cure for glaucoma. They're temporizing. So you still have glaucoma, you still will need to be evaluated regularly to make sure that your pressure stays good, and you may go back on drops again.
So Stephanie's asking, do medications have a lifespan? I was diagnosed with glaucoma at 18 and I'm now 43. Do medications eventually run their course?
Okay, when you said lifespan, I was wondering first if you were thinking how long you can use a bottle. So I guess there's two lifespans. One is how often should you replace your bottle? So the bottle itself will have an expiry date on it. And then when you open a bottle, I usually recommend to replace it every month, because a lot of people will touch their eye or other surfaces with the tip of the bottle and the risk of infection. So, but what you were asking about is something we call tachyphylaxis. So if you're on a specific therapy, does it become less effective over time? It is possible. One of the main drops we use for glaucoma are beta blockers, and there is good literature to show that over a prolonged period of time, beta blockers probably don't work as well because your eye starts to develop extra receptors that the beta blocker is trying to block, so that you don't get that effect as well. And sometimes with a drug holiday, the receptor numbers will go down and then it'll be effective again. But you know, again, you don't know what your pressure is. You can't feel it. So you just have to go in for your regular exams to have that pressure monitored and to make sure that the drug is still effective.
So I'm seeing a few questions here about iridotomy. So Fern is asking, isn't iridotomy a one-time treatment, or does it ever have to be repeated?
An iridotomy should be a one-time treatment. So you're making a hole within the iris. The iris has really no tendency to heal. Only in patients that have inflamed eyes do they sometimes close up. But typically, as long as the opening is patent the first time it's done, it's not something that is usual that you would need to repeat. It should be a one-time thing. An iridotomy, again, it's done for angle closure glaucoma. The most common reason I do iridotomies in people that are at risk for angle closure glaucoma, trying to prevent that from happening. It's not a treatment that you're using necessarily to lower eye pressure, except of course in people who present with that sudden acute angle closure.
Okay. Another question from email, Anne wrote in and asked, well, she said that she has narrow angles that were detected at age 60 and had an iridotomy, now using artificial tears 3 to 4 times a day and taking Vitalux. And she's just asking, is there anything else I can do or take for prevention, and how best to plan ahead for vision loss? She says she also has AMD and strong history of AMD and glaucoma that's led to blindness in her family.
So it sounds like if you weren't on any eye pressure lowering medication, so that iridotomy was probably then successful for the angle closure component. It doesn't mean that you don't get open angle glaucoma. There's not much that you can do in your lifestyle to prevent it from happening. The most important thing is doing routine eye exams. And if you have a strong family history and you have already macular degeneration, I think you said, then I think you should be going in and being evaluated at least once a year. If you develop any other symptoms of problems with your vision, you would want to go more often. Like for macular degeneration, it's good to use what we call Amsler grids. So you have a grid of crossed lines, and you look at that with each eye separately to make sure the lines are looking straight. And if you see any distortion, you go in. To go in and see your ophthalmologist. Unfortunately for glaucoma, we don't really have anything like that, but just really a healthy lifestyle is very important, you know, especially with macular degeneration. It's been shown a lot of green leafy vegetables, eating fish regularly can be good. No smoking. Smoking is really bad for your overall health, but really bad for your eyes. And then just having routine eye exams.
Absolutely. Okay, so in the Q&A, we have Claire has said, I have glaucoma in both eyes and was taking a lot of medication. I had an operation on my worst eye, so I would not have to take all of the drops. But a few months after the operation, the doctors put me back on the drops. Does this mean it didn't work? And she says, my pressure last visit was 18 in the bad eye.
So I don't know what your pressure was before your operation, and more importantly, what your target pressure is. Unfortunately, as I mentioned, these operations are usually not a lifelong cure for glaucoma, and a lot of people get back on drops. How early that happens is very variable. So if your pressure was, let's say it was 26 before surgery and your target was 20, now you're 18 with surgery and back on drops, I would say your surgery was a partial success because you're still needing drops to get to the number you need. However, if your doctor really wanted your pressure much lower, say 12, then it does sound like your surgery's failed and medications may still not be enough, and you may be looking at considering a second operation.
This is a good question. This is from Devin. I know Devin, she's works in vision rehab, and she's asking, is glaucoma screening always a part of a routine visit to an optometrist? She says, we have a lot of clients that are no longer under the care of an ophthalmologist because they have dry AMD and have been told that there's nothing more a doctor can do. But the only problem is now that they don't have anyone checking regularly to make sure that glaucoma doesn't develop.
It should be. I can't say for sure, but it should be. And as I mentioned, just measuring eye pressure, that's not a glaucoma test. So you need to be also having someone looking at the optic nerve in the eye. Now, I know sometimes people charge for that. I think that we're so fortunate with the eye that you can look in it and you can see things directly and you'll know if there's something wrong. But otherwise, they might ask you to do a test like the OCT that I showed. If your vision is that poor from macular degeneration, I think it would probably be very difficult to do a visual field test, but somebody should be measuring your eye pressure and also looking at your optic nerve, and that is part of a comprehensive eye exam.
Absolutely. So there's a couple of questions here, I guess, about positioning and the way that you can move your body. So Lori's asking, are there particular activities such as inversions or headstands that should be avoided? And Claire's asking, like, when you sleep, if you raise your head, does that help to lower pressure? Could you comment on like how that might affect eye pressure?
Okay, good questions. In fact, I published one of the first papers looking at sleep position and eye pressure. So you're right, when you bring your head down lower, your eye pressure will go up. And in people that have advanced glaucoma and they continue to get worse despite having really good eye pressures, I usually will recommend that they try to avoid prolonged head down positions, like in yoga, for instance. Also things like people who sometimes like to read by lying on the couch and having their legs up, that night might not be good. You asked about sleep positions, and so we did a study too where we had people sleeping in a sleep lab and we measured their pressure every 2 hours, lying flat and then lying with their head 30 degrees elevated. And we found that when their head was elevated, their eye pressure was lower. Does that slow progression of glaucoma? I am not 100% sure. It does lower your eye pressure, but what I didn't talk about, because it gets very technical, glaucoma is not just the eye pressure, the gradient between the cornea and the outside world. It's really the pressure around the optic nerve. So that's a balance of the pressure in the eye and the pressure in your brain, your cerebral spinal fluid pressure. And so when you change these positions, sure, when you put your head down, your eye pressure goes up, but so does your intracranial pressure. And we had just done a study in the ICU with people who had catheters measuring their brain pressure constantly and had them move in various positions. And it really wasn't definitive to show if having your head elevated was beneficial for that pressure gradient across the optic nerve. That all being said, if you have glaucoma and your pressure is really good and your glaucoma is still getting worse, I would recommend that you sleep with your head a bit elevated.
Okay. Christine has a good question here too. So she's asking, how do I know I'm putting the drops in correctly? This would be my question too. So she says, much of the drop seems to leak out of her eye. So are there tips that you have about getting those drops in so that they're actually in there?
Yeah. First of all, the volume of a drop is much bigger than the eye can take. It only needs about 20% of that volume. So it is normal for fluid to fall out. I normally would tell patients, if you felt it, you must have probably got it in your eye. Some people do it in front of a mirror so they can actually see. But I think the best thing is to have someone observe you. You know, a spouse, friend, children, have them look at you and ask them, does that look like it's getting in the eye? And they'll be able to help you. Sometimes maybe putting the drop in the refrigerator so it's a little cooler. That would also help you feel it when it touches the surface of your eye, not just maybe the sting of the medication, but the temperature change. So usually if you feel it, but some runs out, I wouldn't worry. You got it in your eye.
Great. I have a couple questions here from Barry. So it's like a two-part question. So one is, can floaters cause glaucoma? And then his other part of the question is, some years ago he had surgery in the form of multiple holes, laser driven in the eye to cure glaucoma. Is this common?
Okay, so floaters doesn't cause glaucoma. So that's the first part. The second is multiple holes of laser in the eye. It sounds to me that that was probably a description for this laser trabeculoplasty, SLT or ALT. That is a treatment for glaucoma. They're actually not drilling holes. They're doing a small laser energy to the drainage area in the eye that makes that tissue function better. Again, it doesn't cure glaucoma. It sometimes needs to be repeated. You can't have it repeated though indefinitely. I usually wouldn't do it more than twice. But it is a treatment for glaucoma, definitely.
So a couple questions here about what are sort of the normal or ideal intraocular eye pressures, and what is like the range of eye pressure from low to high readings with glaucoma?
So very variable. When we look at eye pressure, the average is around 15.5, 16 millimeters mercury. That's the unit that we use. And then we look at the standard deviation, which is about 2.5. So you usually say a normal population falls within 2 standard deviations each way. So most people would say normal pressure is somewhere between 12 and 21. That being said, there are people that have pressures above 21 who don't get glaucoma, and there are people that have pressures under 12 and do get glaucoma. So when you talk about a population, that's great, but when you're looking at an individual, population statistics aren't always very helpful. So we have to find what is the right target for each individual person, and that will depend on what pressure you had when your disease started and how advanced your disease is.
So I have a question here that came in an email, and I think this might be about congenital glaucoma, which we didn't really speak of today, but I'll read you her question. So Stephanie said that she's a parent to a child who was premature at 25 weeks and lost one eye to retinopathy prematurity. And she said the other eye has had more than 25 surgeries to treat ROP and cataracts and glaucoma, born with congenital cataracts, and that she's had a bunch of surgeries to put in to slow the fluid that's being produced and has intraocular valves. So she has kind of two. One is like a comment that childhood glaucoma seems to be treated very differently. She moved from Alberta to Ontario, and she feels like a bit lost in terms of the treatment options being different across provinces. So that's one part. And then she says, is there any options maybe down in the future for stem cell treatments, transplants, other sorts of maybe gene therapies? Is there anything in the pipeline that might help in the future?
Okay, so I can only address the glaucoma part of that. And it sounds like, unfortunately, your child has very complicated eye issues. Congenital glaucoma is treated different than adult glaucoma. It's a surgical disease. So medications tend not to work as well in children. So it's usually surgery is the first step. And as I hear, you've had your child's had multiple surgeries, probably for a variety of different things, including the cataract and the ROP and glaucoma. You know, the fact that you said the treatment was different from Alberta to Ontario, I don't think so. We all are reading the same textbooks, and we should all be treating diseases similarly. It might just be that the disease itself has progressed and the other issues involved in your child's eye health are influencing what can be done for the glaucoma. And that's where you may see that a difference happened when you happened to move from Alberta to Ontario, because perhaps there was no room left for some of the surgeries and procedures that had been done before, and so they're trying other things. In terms of stem cells, there's not really anything on the short-term horizon for glaucoma and stem cells. Right now, stem cells are mostly in the area of cornea, although they're looking at them in the retina, and they are looking at them in glaucoma. It's just not prime time at this point.
Okay, well, we are at 5 o'clock, but there's 2 more questions. So do you have a few more minutes to do the 2 last questions? Okay, great.
Sure.
All right, so Steven says, you mentioned that eye pressure was the only variable for treating glaucoma. I'm wondering whether this might change anytime soon. In particular, I'm wondering whether there's any promising work on protecting or regenerating damaged axons, either through diet or medical intervention.
Well, that's a great question, and I hope they get something else soon too, because we're actually very good at lowering eye pressure with combinations of all the treatments we have now. But despite that, we do still see some people progress with pressures in the single digit. There has been a lot of work looking into other forms of neuroprotection, neuroregeneration. There actually has been clinical studies done, but there is nothing that's available at this time. But I'm hoping in the future there will be.
Great. And last question, a couple weeks ago, we had a webinar on AMD and we were talking a bit about vitamins and zinc. And so Anne's asking, with glaucoma, are zinc levels a concern? So if she's taking a multivitamin as well as Vitalux, is there a concern that that might affect glaucoma?
No, not that I'm aware of. I don't think there's any evidence to show that taking vitamins is beneficial for glaucoma, and nothing showing that it's detrimental.
All right, well, thank you. There were so many questions. That was fantastic. Thank you so much for answering all of those and for everyone to send them in. So I think that's going to wrap us up for today. Thank you so much, Dr. Buys. We really appreciate it. And I learned a lot. I didn't know a lot about glaucoma, so I feel much more knowledgeable now. And this was our first webinar on glaucoma, so we'd love to hear what you think. After the webinar, a survey will pop up. Please let us know if you found this helpful, what you liked, and maybe what we can do better in the future. I also encourage you, as always, to visit our webpage and to sign up for our other webinars. Our next session is going to be on Monday, October 19th, and it's all about the connection between the gut and the eye, and it promises to be very interesting. So I hope you'll join us for that. And that's it for me today. I look forward to connecting with you all soon. Thanks again. Please stay safe and healthy, and we'll see you soon. Bye.